We'll talk about epidemiology, clinical presentation, and this is obviously a cutaneous oncology issue that the tumor rises from melanocytes. It clearly, much more than the others we've talked about, has a much greater metastatic potential. The incidence has clearly increased, although the mortality rate has begun to stabilize for a whole variety of reasons we'll talk about. Early detection is a big deal. You've seen artificial intelligence, you've seen the use of genomics, we'll talk about that a little bit. Early stage melanoma is obviously easy to cure with surgical excisions, and then advanced melanoma, you're back to PD-1 inhibitors and other things that have been used. So, obviously most melanomas are cutaneous, some are not. Every so often we see a nodular melanoma show up somewhere that has come from some other place. The majority are brown or black. Some of them are pink or skin colored or amelanotic. And the attorney side of me has seen too many cases of people being sued for missing amelanotic melanoma. And I'll tell you, I would probably miss it as well. They're very difficult to pick up. So very low prevalence in people who have darker skin types. It is a rapidly increasing skin cancer in Caucasians. Lower rates in Mediterranean countries where they're darker, no surprise. High incidence in Australia, New Zealand, and in this country, South Florida and Arizona. The vertical tumor thickness, you heard during the genomics talk, I mean, this is sort of what we've used for years as the most important local prognostic factor, nothing to genomics. And the diagnosis and the ability to pick up thinner tumors has a major impact on mortality and, for that matter, morbidity rates. And the percentage of thicker melanomas increases with age. It's probably not so much age-related, it's that they've had them a longer period of time. And so, we know that there are a lot of genetic factors, and you see the genomic testing, but there are a lot of genetic factors in melanoma. There are a variety of mutations that occur, and so this is an avid area of research. The strongest independent risk factors for cutaneous melanoma, though, reflect both a genetic susceptibility, the genomics, and obviously environmental exposure as well. And the development of melanocytic nevi, atypical melanocytic nevi, soil antigenes, they're all independent risk factors, but genetics plays a big role here, which is why we tend to evaluate patients for their nevi at a younger age if there's a family history of melanoma. So light-skinned populations, no surprise, have a higher melanocytic nevus count than darker-skinned people, and therefore they have an increased risk of melanoma. Goes together. Superficial spreading and nodular melanoma, we're going to talk about the different kinds, but those are two versions of them. That has the strongest association with having lots of other nevi, usually dysplastic nevi. Whereas lentigo malignant melanoma, the classic sort of superficial spreading type thing that's on the face, that has a strong association with skin type and hair color and not necessarily nevi. So risk factors for cutaneous melanoma, and no surprise, lots of atypical melanocytic nevi. And this is really tough stuff. I mean, we follow them with all kinds of testing now. The maximum reported relative risk for melanoma is as high as 32-fold if 10 or more atypical nevi are present, and 5 or more atypical nevi are associated with a higher relative risk factor of melanoma development. So these patients have to be followed carefully. 80% of melanomas develop in intermittently sun-exposed areas, so it's not necessarily the chronic sun-exposed area like we see with squamous cell carcinoma, but both intermittent sun exposure and sunburn history are identified as independent risk factors. But it's, as I said, not all about ultraviolet radiation. This is where it's different than basal cell and squamous cell carcinoma, because if you think about the people we see, the anatomic distribution of melanoma really does not match the sites of greatest cumulative sun exposure. And melanoma is certainly much more common in middle-aged adults and not necessarily elderly people who have chronic decades of exposure. Despite all that, sunburn in childhood and adolescence are significantly associated with melanoma development, and the duration of sun exposure, so it's not cumulative, but the duration of sun exposure is a strong risk factor, and clearly associated with both ultraviolet B and ultraviolet A, but UVB exposure is the strongest risk factor here. The total number of melanocytic nevi identified, as I said, is one of the important risk factors. So, tanning beds, they're still out there everywhere. It blows my mind. They've been out there forever, despite the fact in 2009 the World Health Organization identified tanning beds as a human carcinogen. Tanning bed exposure before the age of 35 is a statistically significantly higher issue with melanoma development. Suberythema dosage of ultraviolet radiation definitely causes DNA mutations. And so there's a significant misunderstanding in the public, not so much in us, that avoidance of sunburns and use of sunscreens prevents all skin cancer. That is not the case. And so obviously we talk about all the factors. So I said I was going to talk about the different kinds of melanoma because they are different and we need to think about them differently. There's superficial spreading melanoma, which represents the most. It's almost 60%. There's nodular melanoma, which we worry about in some ways the most because they tend to be thicker. That's roughly 20%. There's lentigo maligna melanoma. There is acral lentiginous melanoma, so on fingers, toes. And then there's this unclassifiable group, which are always problematic. So superficial spreading melanoma, most commonly seen in fair-complected people. It represents the majority of the melanomas we see, 60, 70%. And again, think about the issue of sun exposure. This is not usually on the face. It's on the trunk of men usually and on the legs of women. 2/3 are present with some form of regression, which is what you see as the hypo or loss of pigmentation there. And then if you use dermoscopy, which we increasingly have used over the last decade, you see all kinds of networkless areas in those areas. And initially they're characterized by horizontal spreading. Eventually they get to be nodular. And a half actually do occur in pre-existing nevi. And so you can see some of these pictures. This is from Jean Bologna's textbook. Jean and I were actually classmates together at Yale Medical School and even floor mates together at Yale Medical School. We go back a lot of years. Again, clinical images, again, you see the varying colors, superficial spreading, and again, superficial spreading. And you can see what dermoscopy looks like. So that was superficial spreading melanoma. I worry about this one a lot more. This is nodular melanoma. It's the second most common form of melanoma in fair-skinned individuals, usually a little bit later in life, more like 6th decade of life. It represents roughly 15 to 30% of all melanomas, and they can occur anywhere. So where the superficial spreading is predominantly truncal in men, legs in women, this is anywhere, but most frequently on the neck, head, and trunk. Also more prevalent in men, generally is going to be dark. They can ulcerate or bleed. They have this rapid vertical growth phase stage, which of course does not bode well for long-term prognoses. And they're often thicker and more advanced at the time of diagnosis. And then there is lentigo maligna melanoma, LMM. This actually doesn't represent that many of the melanoma group, but it's seen, it's 10%, usually in elderly people. And in this case, it's usually sun-damaged, chronically sun-damaged skin, and therefore most commonly on the face. And where this gets misdiagnosed all the time is people have what look like solar lentigines, age spots, often misdiagnosed by primary care doctors, can clearly be misdiagnosed by dermatologists. But if it's growing and or you treat it with other things and it doesn't respond, you have to think about melanoma. It's slowly growing, it's asymmetrical, brown, black, some color variation. And ultimately, it can become invasive and become lentigo maligna. And so that is an in situ melanoma on sun-damaged skin. And 5% of those go on to become invasive melanoma with all the consequences. Dermoscopy has some characteristic findings. So this is lentigo maligna melanoma. To me, doing this for so many years, that doesn't look like a solar lentigo. But I can tell you people have misdiagnoses of solar lentigines and even seborrheic keratoses. So you got to think about this a little bit. And someone who runs, I have a cutaneous oncology practice, but a large laser practice, I get people sent with spots like the one you see on the left there all the time, sent for laser treatment of their brown spots. And I look at the thing and I go, probably is a solar lentigo, but why don't we do a biopsy first? And so I take a little teeny punch biopsy, and every so often it is a melanoma. Again, you see the images on dermoscopy, pretty classic findings of lentigo maligna melanoma, in this case on the nose. Acral lentiginous melanoma, relatively uncommon, again in an elderly population, occurs on palms and soles and around nails, therefore the acral name. Represents a small percentage of melanomas, about 5%. And this is actually very common, evenly common in all ethnic groups because darker skin types tend to have fairer skin, palms and soles. It is the most common melanoma subtype in darker skin phenotypes, and it represents 70% of melanomas in blacks and 45% of melanomas in Asians. This, of course, is a variation on that. It's melanoma on the nail, and a disproportionate amount. These are diagnosed at advanced stage. I don't see these very often. You do have people coming in all the time with a streak on their nail, and there's always a concern about melanoma. But if that streak does not involve the cuticle, which is the growth center of the nail, then I don't worry about it. If I see any pigment involving the cuticle, then I do a biopsy on it. So you've got to at least think about this. Again, you can see that. See the pigment there on the nail, but you also see some of that pigment in the cuticle, and that raises the risk of melanoma. Another example. And then there's amelanotic melanoma, and I got to tell you, I think I've seen in my personal practice only one of them in 35 years, and I also missed it in the beginning. I don't remember what I treated for. I probably treated for psoriasis or something. Didn't respond after a couple months of topical steroids. I did a biopsy, and I was shocked. And there are a disproportionate number of medical malpractice cases on this, and they're tough because there may be expert witnesses that get up there that say we should have picked this up earlier. I disagree. I think this is the kind of thing that any reasonable dermatologist, primary care physician would not necessarily be calling a melanoma in the beginning. But if it doesn't go away and you do other things, a month or two later, then you have to biopsy it. And usually they biopsy because people think of basal cell carcinoma, or even warts or squamous cell carcinoma. But got to look at it. Look at this. I mean, these look like scars or dermatofibrosarcoma protuberans. I mean, they really don't look like melanomas, and they were. So. Melanoma pregnancy, occasionally we see somebody who comes in who's pregnant, usually a woman in their 30s who's got this. We know that hormones and growth factors do stimulate melanocytes, leading to increased pigmentation in general. 10% of women or more have darkening of melanocytic nevi the first 3 months of pregnancy, kind of stays that way. There is no demonstration of an increased incidence of melanoma or worsening of melanoma during pregnancy. And transplacental metastases have actually been reported, but they're really rare. Surgical excision and sentinel lymph node biopsy are performed based on stage. And so I'm willing to watch them a little bit, but not too long. Ultrasound, MRI, obviously are okay. CAT scans you're not going to do, particularly around the belly, because if they're pregnant. And then women with diagnosed high-risk melanoma should wait 2 years before becoming pregnant again. And I think that's pretty much the standard, because 2/3 of recurrences will occur within a year or two. Childhood melanoma. Anybody here ever see a kid with a melanoma? Because I have not. You have. Okay, you have everything. I see that. I'll get you up here next year. Okay, very rare. They say 2% of melanomas are present in population younger than 20. I think that's probably not that high because I just haven't seen it. 0.3% of melanomas are seen in those younger than 14 years of age. Melanomas with Spitz features are more common in this age group, but the problem with that is Spitz nevi are relatively common in kids and they are benign. But survival and prognosis in childhood melanoma is the same as adults, and it's clearly stage development. So staging. So we heard a little bit about this before. We know how we followed people, and historically, they have a lower risk or a higher risk, and whether they get sentinel lymph nodes, and this is the Castle test that you're going to hear about over and over again, which I don't know that it's the standard of care at this point, but it's becoming close to that. And the reason for it is, if you look at the stage of diagnosis, the staging at diagnosis, and then the staging at melanoma death, it's very different. You've got so many people in stage 1 at diagnosis who end up not being stage 1. So we needed something that helps us with prognostic accuracy, and that's where genomic testing comes in. And so you take these, and for us in dermatology, really it's the people with melanoma, not melanoma in situ, it's not an issue, melanoma greater than 1 millimeter in depth, you tend to send them on. It's this group that is under 1 millimeter in depth, where I historically would tell these people, look, I can't say you're going to survive this thing, but the chances of you dying are somewhere like you and me getting run over by a truck today. And that's what I used to say to people, because that's all we have. But now we can break it down much further because of this genomic testing that looks at the different 31 genes. And so it is this group of less than 1 millimeters, and it has definitely changed the way we follow these patients because we divide them into these classes 1B, 2A, and 2B based on 31 gene analysis. So in the end, we've got lots of ways of treating people and evaluating them. Surgery is still there, and lymph node dissection, frankly, we're using less and less now. There's not a lot of evidence that lymph node dissection actually has any long-term impact on survival. But there is adjuvant therapy, there's immunotherapy, and there is genetic testing. Okay, so that's my talk on melanoma.